I'm now going to hand over to our first speaker, and that's going to be Damien, and he will be helping us to understand how we can move forward on the issue of biomarkers. Damien. Apologies.
Thank you so much, Rose. Good afternoon. Buenas tardes. Hope that you are doing fine. Really happy to be with you today. Thanks a lot to the Global Heart Hub for the very kind invitation. I am the lab guy, so I will share with you my passion and my dreams. I have no conflict of interest for the session today. I have to acknowledge some unofficials. I am addicted to chocolate. Dark because of the polyphenol, good for cardiovascular. And guess from which country are the best chocolate?
Belgium.
Okay, Steven, you won. Chocolate from Belgium, just after. I have to confess that I am already a fan of music, dance music from Belgium, and I do some exercise and support some crazy football team, the Paris Saint-Germain. They were defeated yesterday. Okay. I am engaged in cardiovascular care, and I will take the example of heart failure. We are fighting all together, and we have great results. I am fighting as a director of a clinical lab, academic lab hospital in Brussels. Just the grey building in the middle. We have 12,000 square meters of capacities, 300 workers. We are doing routine lab tests. We are doing also molecular, including NGS or pharmacogenetic, which are weapons that your physicians are using. You might know the classical pathway of a lab, or you cannot imagine what is behind your blood draw. There is the cycle of the laboratory medicine, so the physician orders the test, tubes arrive to the labs, we have what we call the pre-analytics, where we are centrifuging the tubes, where we are splitting and pushing back to the analytics. And we had huge automation process. We have robots in the lab, so there is the science of the clinical validation of the test that we are using. There is also process engineering behind the labs and a lot of technologies behind the scene that you cannot imagine. There is the post-analytical phase where you have medical experts, pharmacists, MD, doing the medical validation of the lab results before they are going back to your physician. That's the regular pathway with usually venous blood sampling. Invasive. Fortunately, we have biomarkers, in the case of heart failure, which are international standard for the diagnosis. Brain natriuretic peptides are the biomarkers. They are in the universal definition of heart failure. They are part in the guidelines in all over the world. And they are easily performed in all the clinical labs. So interesting for different aspects. Assess the state of heart failure. Is it an acute episode where the concentration of the natriuretic peptides will be clearly increased? Or are we more in a chronic phase? The level will be lower and the physician can know the status of your patient, more acute, more chronic, and how can I adjust the treatment or the response according to these biological biomarkers. So very interesting to reflect the dynamic of the disease. We can do also with our regular lab pathway subphenotyping. What is the meaning of subphenotyping? Behind a disease like heart failure, there is many physiopathological pathways that are activated in response to the suffering heart. The kidney, the inflammatory process is activated. we can, in addition to the natriuretic peptide, do this testing. So the physician can see, okay, my patient has this biological profile, it's safe, or unfortunately, it's a higher risk patient, and I will adjust my treatment. So on a single blood draw, we are able to provide a response which is useful for the diagnosis, early detection, but also for the risk assessment, monitoring, management. We have some game changer coming in our field. That's clear, the technology is there. From the regular path, we have the clinical value, we have the value for the patient. If you know, you can be more easily empowered, and that was discussed already a lot today. The aspect of education is fundamental, and we need to provide that. Operational value, laboratory medicine is cost effective. We're very well documented. So we have the economical, operational, and we have this shift which is ongoing. I was dreaming, Neil, we know that, and I'm still dreaming of having more capacities in ambulatory care, and it's now possible. We have point-of-care technology which are there, and it's not anymore venous blood draw. We are on finger prick, less invasive sampling. The results can be delivered straight to the physician or the nurse in 4 to 5 minutes. So making more possible the screening in primary care, making possible the follow-up after the hospital stay, so the helpers, the patient, the nurses can be more efficient with the technologies. We have connectivity to connect the system. We have the data space which is coming, where we can push and use dynamic care pathway with this data from the lab. And we need to be all engaged in this multidisciplinary transition. The needs is to provide a high-quality environment. So we need to ensure, as lab, that the players, pharmacists, GP, helpers, patients, have quality standards, competence, quality control. So if we are ensuring the quality of the system, we are ensuring the patient safety and the safety of the medical decision. So we can transition the technology, but we need to be all together with these new standards, new possibilities, making the dreams coming true. And we need also to be all engaged to ensure that in the different regions of the world, we are able to provide equitable and affordable access to this new technology. That's clear. We are shifting, and it's also already highlighted today, to this use of the prevention window. With this new technology, we can clearly do more empowerment, more prevention, reduce the time to the accurate diagnosis. And it's not a dream, that's currently a real perspective. If we are all engaged, we can transition. That was already mentioned in the previous session. In high-risk population, like diabetes, we can use this technology to identify the high-risk individual. Heart failure is an underappreciated complication of diabetes. So we can screen, GP can screen diabetes patient with these new technologies, POCT for natriuretic peptide testing, and if the patient is judged as high risk, it could be referred to the cardiologist. So we are engaged to transition the technology, but not only for a rapid, but also for a dynamic care pathway. If we diagnose early or detect early, we have new treatment opportunities. That's clear. The dream is also there because of the progress of the pharma industry. Artificial intelligence is there also to ensure that we can monitor the number of multiple points of measurement that we will deploy. It's too much for a simple biologist like me. If we are assisted by the artificial intelligence, we can have checkpoints for the sensor, the point of care, So we will use AI for that. We will also use AI to combine the data, because we have the digital footprint, we have the sensors, we have the biomarkers, and we have algorithms to be more accurate in the clinical decision support system. So it's not the AI alone, it's AI to amplify the human intelligence. And I am at the end of my talk. I was not sure, Rose, and I have chocolate for you also. I was not sure that you will do this shaking and speed up, so I prepared just one slide and some music if you want to shake again. And let's see if the music comes through. So you can already shake, move. And I am a believer that happiness is also good for cardiovascular care. So thank you very much.
Thank you so much. Wow, well, that was great. If I knew there was music, we could have used it earlier. That was great. Thank you very much. And it's so exciting to hear what's coming, that there are new innovations that will move more sophisticated tools right in the hands of patients and primary care, and where we'll be able to use it more effectively. That gives a really nice bridge to our next presentation, which will help us to understand the health economic case for some of these tools that we've been talking about. And again, this must be an area that is evolving fast as the cost of these new tools are starting to come down. So please.
Thank you very much for the invitation, Global Heart Hub. I feel very excited to be present here with you and share some of our work that we do. I use big data to answer those difficult questions in terms of investment or disinvestment of new technologies. So I have nothing to disclose except the fact that I'm part of the economic subcommittee that we make decision about which new pharmaceuticals should be reimbursed in our healthcare system in Australia. So what I'm going to talk through today, I'm going to take you through the journey. So why do we use, first of all, health economics for decision making? I'm going to give you some of the examples that we had with regards to familial hypercholesterolemia, which I'm going to refer from now on FH because my tongue rolls out when I always pronounce it. And then I'm going to sort of talk about some of the new initiatives of population genomic screening and how is this changing the landscape, and how you're going to be pleased to hear about those new initiatives. And then I'm going to challenge the current status quo with regards to primary prevention of cardiovascular disease. And this is going to be in terms of how we use nowadays the current risk scores that we have in clinical practice, and how these risk scores are not fit for purpose, where we want to be in the next 20 years. And then I'm going to sort of talk about some new initiatives for primary prevention of cardiovascular disease, and some take-home messages from my talk. So why do we use health economics? It's inefficient to think that governments should be funding every new technology that comes in the market. And not all prevention strategies that we have available are effective. So we have to make choices and priorities. And opportunity cost is something that you have to think about over this presentation. I'm going to come to that concept over and over again. So what does it mean, opportunity cost? Opportunity cost means that if we have a $60 billion to spend in our healthcare system today, we have to actually be able to accurately predict that with the same amount of money, we are going to buy more health in comparison. For example, if we choose to spend that $60 billion in cardiovascular disease, can we buy with the same amount of money better health for other health conditions in our healthcare system? And also you have to understand that there is a growing gap between what medicine can do and what is economically feasible to do. So that's why the importance of health economics. So how do we make decisions in our healthcare system? First of all, when a new drug comes into the market, we not only need to know about the safety and efficacy of medication in terms of clinical trials, but also we have to focus on effectiveness and cost effectiveness. But lastly, we also have to think about affordability and appropriateness, so opportunity cost. Also, what you have to understand that different governments across the globe uses different perspective for decision making. First of all, countries like UK or Australia, they probably use a healthcare perspective for decision makers. Countries like in Scandinavia, they use a societal perspective. What does this mean? It means that we include the cost to the healthcare borne by the healthcare, but also we use the cost that borne from us not going back to work due to the disease. So I'm going to talk today, as I said, I'm going to take you through the journey of FH screening and treatment. As we said during the whole day today, there are two aspects of treating the disease. First of all is identification and diagnosis, and the second of all is management and prevention of a cardiovascular disease. So in 2017, we started this new concept, do cholesterol years matters in FH population. So what we did within these 3-4 years, we've used 2 case studies. The first case study was using Dutch data, which is one of the most successful FH programs that was implemented in Europe. And the other case is Australia, where the program was implemented in Western Australia. So what did we found? So obviously the Dutch program, which started in early 90s, Ministry of Health gave around 10 million or 10 Deutschmarks at that time to implement the cascade screening program. And during this cascade screening program, we found that around 11,000 children were screened, and among these 11,000 children, 50% of them had FH. All right? So obviously, what did we did with health economic models? So what we wanted to show is that including this cholesterol years from the early age, does it matter to treat early in a patient's journey or not? So obviously we were comparing what has happened in Netherlands with the current practices that are happening across the world. And we know that people with FH get treated at age 35 or 45 globally, and majority of them, only 50%, achieve the desired goal of LDL-C. The same study was also conducted in Western Australia. So what we found that if we start early treatment at age 10, it's going to actually save almost 8 years in comparison to current practice. What we also shown is that not we also saved lives, but we also saved cost, because both in Australia and in Netherlands, cascade screening, it was not only cost effective, it was cost saving, meaning that it was saving lives, but also was saving costs to the healthcare system. What is the current knowledge? So we did a systematic review recently, which shown that majority of the screening strategies that we apply in FH, most of them were cost effective. So majority of the studies shown that cascade screening, opportunistic screening, systematic screening, and population-wide screening were cost effective. What are some of the new initiatives in place? You will be happy to hear then in Australia, we did this population genomic screening of young adults with FH. So we sort of conceptualized the model that we would screen people from age 18 to 40. So what we found that if we would start population genomic screening in comparison to status quo, when we are only detecting 5% of population, it's cost saving. Then what we did, we also actually look if we would implement such practices in other European countries and in US, it's going to be cost saving from a societal perspective. So what are some of the new initiatives for population genomic screening? So Monash University initiated in 2022 the world's first DNA screening pilot study. So we have recruited around 10,000 patients, adults from ages 18 to 40. So this is particularly interesting in terms of opportunity cost. Bear this in mind. First of all, what we've looked at here was looking at diseases such as breast cancer, ovarian cancer, FH, and Lynch syndrome. So what we found that the widespread preventive genomic screening for multiple diseases was cost-effective from an Australian healthcare perspective. So this study just came out today in Lancet and actually showed that FH, if we would sort of look these cancers in isolation, it's not going to be cost effective if we would do population genomic screening. But if we would add FH into equation, it actually makes more sense, and obviously it's more cost effective. So those diseases, if we look individually, they are not going to be cost effective. But once the FH is in equation, it's going to be cost effective. When we look at it from a societal perspective, it's going to be cost saving. So how can we move from a reactive to preventive healthcare in CVD? So current prevention approaches are mostly initiated in pre-disease trajectory. So you can see here that current problem is point of intervention, where we start most of the intervention is at age 50. So what we are trying to show here that current clinical tools bias detection towards short-term decision making. And as I mentioned before in a group that we were working, that majority of these risk scores are biased towards age and gender. They don't put as much weight on the risk factors. So basically, if we would start early at age 30, what would that mean from a patient's perspective? So here are the results. So what we've used a UK Biobank data, and with the UK Biobank data, we showed that if somebody would start at age 30, in comparison to somebody if we start at age 60, we would reduce the risk of heart attacks by 51% in comparison to 16%. What does that mean in terms of cost effectiveness? We just shown that if you start early in life, at age 30, in comparison to age 40, 50, or 60, it's much more cost effective than starting later in life. What does the future hold for cardiovascular disease? So global initiatives such as Lp(a) task force potentially will generate new evidence about Lp(a) as a major inherited CVD risk, with 1.2 billion population across the world that has Lp(a), and obviously 20% of population, they don't know that they have the disease. So obviously, this initiative is going to generate health economic evidence, but also improve management of CVD prevention. So take-home message, so novel strategies including population-wide screening, somebody else mentioned newborn screening, may be cost-effective in combination with cascade screening. As I mentioned before, reconsideration of current approaches to current primary prevention of CVD that focus on 10-year absolute risk and instead of focus on more early and substantial lowering risk factors. So we have to take in equation cholesterol years, blood pressure years. You are not an individual that you are going to go to that risk score at 50 years of age. We have to consider your cholesterol level from age 0. And also, as I mentioned, such as new initiatives probably will transform the landscape of cardiovascular disease. So thank you for having me.
Thank you very much, again, raising some of the background information to understand how policymakers would look at some of these issues. Because, of course, when we're talking about changes to the health system and new systems in place, the first question a policymaker is going to ask is, Can we afford it? Will it make a difference? So thank you for sharing that. A lot of issues came up there about genetics, and I think that's a perfect bridge to our next speaker, who's going to help us understand innovation in genetics. The floor is yours.
Thanks very much. Well, thank you for inviting me to be at this meeting. I'm a cardiologist by background. I spend most of my time running a research team studying the genetics of cardiovascular disease and, crucially, how we make genetic information useful in the clinic. So a gene is a unit of genetic information passed down from parents to children. It's essentially a segment of DNA, usually that contains the instructions to make a particular protein that has a particular function in the body. And you may know that almost every cell in your body has 2 copies of every gene. And this cartoon here on the left shows how long strands of DNA are wound up and crammed into every cell. You've got about 2 meters of DNA in every single cell in your body. And the image on the right shows how much information that is. This is a printout of one individual's genome. So it's a fantastic system. Now, if you compare the DNA of any 2 people, there'll be millions of differences, and they lead to differences in many traits: height, hair color, and of course, heart size, heart shape, heart function. So I want you to consider 2 different ways, fundamentally different ways in which genes can affect our health. So on the one hand, some cardiovascular diseases arise when one or both copies of a single gene is faulty. Those are called monogenic. We've heard about familial hypercholesterolemia. Cardiomyopathies are another example. On the other hand, there are other traits, characteristics that run in families but not controlled by any one gene. There's not a single faulty gene copy, but the combined effect of many variants that individually have tiny effects, they all add up in combination to lead to, for example, a slightly less efficient heart. And there are lots of cardiovascular diseases that arise in that way: hypertension, high cholesterol, coronary disease. And of course, in the real world, there's also a spectrum in between. Let's just skip over that. So how does that translate into genetic information being useful for a patient? Well, it's most useful in the setting of single gene disorders. So I'm going to start by talking about those, where if a cardiovascular disease is caused by a faulty copy of one gene, well, understanding that fault can tell us a lot about how the disease is going to behave. And there are 3 ways we might use the information. We can use it for diagnosis, for prognosis, i.e. predicting the future, and sometimes to guide therapy. So this table's from a consensus statement that came out last year that summarized all the different ways genetic testing can be useful in cardiovascular diseases. It might be a useful reference for some of you. And I'm going to illustrate that now by talking specifically about genetic testing for cardiomyopathies. So normally genetic testing is done when someone's already known to have a cardiomyopathy. So it's not really about early detection. We've already made a diagnosis. But what it can do is quickly get us to a more precise diagnosis. So here are 3 forms of cardiomyopathy that present very similarly. They all present with thickening of the heart wall. It might be difficult to work out which one you're dealing with. But genetic tests can lead us to a more specific diagnosis that leads to precise therapy. So Fabry disease is due to a lack of an enzyme, and we can replace that enzyme. Amyloid is due to an excess deposition of abnormal protein, and there are new therapies coming out that either inhibit production of those proteins or stabilize them so they don't get deposited. And increasingly, we've got a whole genomic toolkit that's starting to come online that I think over the next few years is going to let us turn off faulty genes, replace faulty genes, even repair faulty genes. But where genetic testing is really useful for early diagnosis is in managing families. So when we diagnose someone with a cardiomyopathy, we invite their immediate family to have ECGs and heart imaging to see if they're affected. So imagine a family member, they have no symptoms, they're invited for a heart scan, and they're waiting to hear, is my scan normal or abnormal, what's going to happen? Well, actually, either way, they end up staying in the cardiology clinic. Well, why is that? It's because most cardiomyopathies don't appear till adulthood, maybe age 50, 60, even 70s. And so a normal scan today doesn't mean that you don't have a genetic predisposition that's going to result in a cardiomyopathy that's going to reveal itself later. And this results in a huge lot of worry. It's a big burden. So if we rewind and we imagine instead that we've done genetic testing in the first person in the family who was found to have disease, and we pinpoint the genetic change in them, we don't then need to do a heart scan in their relatives. We can simply do a blood test, examine their DNA, and see if they share that change with the affected relative. Those who do can get appropriate care early. Those that don't, well, we can give them the all clear and reassure them. And understanding the genetic basis of disease also helps families to plan more broadly. So if you have a child with cardiomyopathy, what's the chance that another child is going to be affected? If you have cardiomyopathy yourself, what's the chance of passing it on? And if that chance is high, would you like to consider doing something to prevent that? So a couple might use a donor egg or a donor sperm to avoid sharing their genetic risk. A couple could choose in vitro fertilization, test embryos, select an embryo who doesn't carry the genetic predisposition in the family. And this is all available today. So we've talked about people who have inherited conditions. We've talked about families where there's a family history of inherited conditions. How about the wider population? Can we use genetic testing to screen there? Well, we've heard a little bit about FH already. Every year, more and more people are having their genomes sequenced. The left here is showing a research study in the UK that's about to sequence the genomes of 100,000 newborns to look specifically for diseases that affect newborns, so metabolic diseases that need early treatment. But we could look to see whether there are genetic predispositions to cardiomyopathy, to channelopathy, inherited arrhythmias, FH, and so on and so forth. In the US, there are actually guidelines that recommend everyone who has any genetic test for any purpose should be actively screened for about 70 odd genes that include all the cardiomyopathy genes that I mentioned earlier. And there are now companies offering genome sequencing explicitly for, as a form of health screening. The truth is, I don't know what to say to people who have genetic changes found in that context, for the most part. We don't actually know what their risk is. For many of those people are never going to develop disease. For some variants, the risk might be 1 in 50. It might be even lower than that. Screening is going to generate a lot of work. There'll probably be 1 or 2 in every 100 people who have their genome sequenced who will have something, a cardiovascular finding. And some people will benefit. FH is a slightly special case, I would say, but if we look at all the other conditions, some will benefit, but a lot will be harmed by being called back for ongoing surveillance, perhaps advised not to pursue their chosen career. We need to find the balance, and we don't know where that balance is yet. So to summarize, for these rare inherited forms of conditions, absolutely, screening families, early detection in families can be cost-effective, even cost-saving. But opportunities for wider early diagnosis, there's still a lot to learn. It's also worth noting it's expensive from a global perspective. It needs a high level of skill and training. There's a big research bias towards European ancestry. So when we think globally, understanding the global genome is hugely challenging, and there are some big knowledge gaps as well. So coming back to this image, how about the vast majority of cardiovascular disease that isn't due to a faulty copy of a single gene? There's still a genetic contribution. We have tests to measure those as well. And they are called polygenic risk scores, genomic risk scores. They essentially integrate hundreds of thousands of variants across the genome to try and predict genetic risk. I'm going to show you 2 ways of looking at these scores to predict coronary disease, one optimistic, one pessimistic. So the optimistic view is shown here. In the interest of time, I'll just look at the leftmost panel. It's looking at the predictive power of various risk factors that are normally measured in early detection programs. The further up the plot each dot is, the better it is at predicting coronary disease. You can see the 6 risk factors we routinely measure, and then next to them, genomic risk scores. It's better than any other single thing that you can measure in an individual. But in practice, of course, doctors don't measure one thing. We ask you a whole panel of questions about smoking, diabetes, family history, add it all up. The next dot along, which I think is green, is showing those conventional risk scores, and they're better than genomic risk scores. But if you add genomics in to your kind of risk assessment, again, you get an improvement. So the best risk stratification we have at the moment would include a genomic risk score. The problem is, if we now look at this second view of the same data, the purple line is showing the distribution of genetic risk scores in the population. The height is the number of people, so you can see there are lots of people with risk scores in the middle, a few with low risk scores, a few with high risk scores. Yellow is then the distribution of scores in people who do have coronary disease. It shifts over to the right. They do have higher risk scores, but what you can see is that they overlap enormously. So if we were to imagine a test for an individual patient, a predictive test, that says you've got a positive test if you're to the right of that red line, you can see about 5% of normal people who are not going to get coronary disease would be told they're at high risk, and most people who are going to get coronary disease would still be to the left of the line. So the test would make a lot of false positives, and actually it would miss most people who are going to get coronary disease. So for individuals, it's not very powerful. So to summarize, it's no doubt that genetic information is useful, it does improve predictions. Crucially, you can measure it early, much earlier than you can measure any of the other things. So you can potentially make lifestyle recommendations earlier, diet, exercise, you can change things before the disease is established. But for making a prediction in an individual, actually none of our risk factors are really good at telling an individual person what's going to happen. And when we come to cost effectiveness, genomics is still expensive. So it's really not cost effective if that is why you're doing the genetic test. You'd have to order something like 5,000 genetic tests to prevent one cardiovascular event. But if you already have the data, because you're doing some other genomic program, you're doing genetic testing for something else, the data is essentially free, well then absolutely it can be useful. And we still have all the challenges of ancestral bias, implementing pathways. It's still a complicated landscape. So I think that's my time up. My conclusion is, in rare forms of cardiovascular disease, genetic testing is very useful. It's very useful in particular for managing families. There may be a role for screening the wider population. When we think about common diseases, genetics works, and then it comes down to challenges of implementation, cost effectiveness, and whether it's the best use of resources. So thank you very much indeed.